We will be presenting 3 cases, and the brilliant presentations we had before. We have learned a lot. Thank you very much for all the teaching, all these conditions that are so hard to diagnose and treat. These first cases, I will ask the speakers to use 7 minutes so that we have at least 2 minutes for Q&A. From Dr. Maria Asuncion. Well, she's the chief of the EB department at San Juan de Dios Hospital in Barcelona. She has wide experience. We were really surprised, overwhelmed by her presentation. And also Professor Cristina has. She made such a nice presentation. She is from Freiburg University in Germany with a lot of experience in EB and genetic disorders. So let's move on with the cases. Thank you. So, good afternoon, everyone. Yes, we can hear you. The dermatologist, the pediatric dermatologist responsible for the dermatology department at the Córdoba Children's Hospital. Thank you very much.
Hola, buenas tardes. Bueno,
good afternoon. This is a case I have been following since birth. It's the girl is now 15. I saw her for the first time after birth. She was a term baby. The only history, she had a sister, an older sister, with dystrophic blistering epidermolysis. That was the clinical suspicion. We had no genetic testing. This is the baby. You can see this blister in the hand, in the lip. She has an ulcer. The tongue is very bright. That's very important to see in the neonatal phase because this is indicative of the clinical presentation of epidermolysis. We can see here the nail involvement. These are broken or ruptured blisters, denudation here. Well, at the time, 15 years ago, we suspected a recessive dystrophic type of the disease because of the clinical picture. At the age of 3, she came to us because of this erosion in the vulva. We did a kidney ultrasound and other clinical tests. We decided to do a biopsy. The biopsy shows this detachment with a subepidermal blister. We see that the roof is the base of the epidermis. This was an indication for differential diagnosis like erosive lichen or other ideas. So this is the patient outcome. Well, we treat her with an MDT, the gastroenterology department at the age of 2. Well, so we had been following the patient and see here this indentation of the esophageal wall under the cricothyroid plane. This was an indication for esophageal dilation with a biliary balloon because the child had some difficulty swallowing. So here, this is the vulva. You see here the outcome at the age of 9. At the age of 12, this was very, very disturbing and painful. We had tried ointments and creams, everything we had. But look here, how interesting, the lesion in the tongue. Initially, I used to see a different tongue with less papilla. Now this is dentition is good, less blisters in the skin, limited nail involvement for a dystrophic type of the disease. And finally, we could do the molecular test by SEDIGEA. They show the mutation of exon 3, which has already been described. It's interesting because in Córdoba here, between the provinces of Córdoba and Santiago, there's an important incidence of this mutation in exon 3, and it seemed to be or to correspond to endogamy, consanguinity of the population. Well, here again, the patient is 15 years old. She is a very problem patient, psychologically affected. She has lovely nails and hair. The skin is really healthy. And however, this very, very, very severe involvement of the genital mucosa covering even this area. Her sister has a dystrophic type of the disease, but no mucosa involvement, only the esophagus. Today, at the age of 15, you see this here, the tongue, and her hands as we saw before. We administer tacrolimus, curefini, this ointment that I talked about before, and also in the protocol, she's in the protocol to be treated with oleogel.
Resultados todavía no tan satisfactorios como la verdad habíamos apostado. Entre los procedimientos que ha efectuado, ya lleva con 15 años 2 dilataciones con el balón biliar, y bueno, revisando la bibliografía, entendemos que se trata, ¿no es cierto?, de esta forma de epidermolisis ampollar distrófica inversa, donde el colágeno tipo 7 es el afectado. Es extremadamente rara esta forma de presentación, habitualmente está asociada a esta mutación genética en el COL7A1. Las ampollas ocurren en el periodo neonatal, como nos pasó a nosotros. En el caso, las lesiones cicatrizales no son tantas en el caso de nuestra paciente. Es importante sí destacar que parecería ser que estas formas inversas van progresando su compromiso mucoso a medida que los niños crecen y se van localizando en las mucosas y en los pliegues, y esto está bastante parecería estar vinculado a esa termolabilidad que tiene el colágeno 7, menos estable en las áreas más cálidas del cuerpo. Una de las sugerencias que se ha propuesto es mantener esa zona fresca con baños de asiento, que coma cosas que no le generen mucho calor, estar en lugares frescos. Bueno, finalmente, realmente creo que a la fecha, con 15 años, tenemos el diagnóstico molecular, tenemos todo, pero no tenemos la solución para darle a esta chiquita que hoy está en el inicio de su adolescencia, con toda la preocupación que imaginen que le puede generar tener una lesión en su zona genital. Realmente es complicado. Aquí me gustó, entre las caminatas que uno a veces hace, acá en Córdoba, encontré esta flor, y fíjense qué curiosa flor. Se la llama Clitoria cordobensis o albergilla serrana. En la naturaleza está casi toda, está todo en la naturaleza, hay que buscarla. Interesante, me gustó acompañar esta presentación con esta flor porque hace mención a la zona genital. Bueno, muchas gracias.
Muchas gracias, doctora. Muchas gracias, muy interesante. No sé si vamos a hacer la...
Doctor, very interesting presentation. I don't know if you're going to have questions and comments now or after the 3 presentations. I don't know what you prefer. Let's have the 3 presentations and then the comments at the end. Great.
Bueno, ahora el segundo caso...
So our second case.
Perdón, pensé que estaba en el doctora, el segundo caso a cargo de la doctora.
Yes, the second case is by Dr. Silvina de Freijo, a pediatrician and dermatologist from Salta. a province in Argentina, and she's going to be presented now. Thank you. There we go. Well, good afternoon. Thank you so much for the invitation. I'm going to be presented a case of EB, generalized severe EB simplex. This is a year and a half year old baby, controlled pregnancy, a term baby with correct weight, was autosic delivery without family history of blisters or lesions. Here you can see at birth these extensive lesions throughout the trunk and the limbs. You can see again the loss of skin, the erosions, very painful. Also involvement of the oral mucosa, periumbilical, and the greatest involvement was in the hand and feet. You can see these lesions, some were very dry, others were very tense, a lot of itching for the patient, very painful, a thickening of the skin in the plantar area, and dystrophy of the 20 nails. At 8 months of age, he had to be hospitalized due to respiratory insufficiency. He had to be put into a ventilator. He had suffered sepsis. We did an endoscopy and found a supraglottic granuloma in the left vocal cord, seen as secondary to the underlying condition or due to GERD. The clinical evolution was good, and he was discharged. For laboratory tests, we did the following. Then we did histopathology, where we found endermoepidermic blisters and separation. Here in the genetic study performed by Cedigea, we found a variant of the keratin 14 gene with a substitution of proline 377. And this variant was not found in the parent, so we thought it was the de novo variant. We have then the diagnosis of a generalized severe simple EB. In a series of cases, the same mutation was reported in a patient in Hong Kong. The treatment was multidisciplinary, and of course, for the family, it was a daily training to perform this with the different bandages and patches in different areas of the skin. So they were helping with the treatment. He also had to take oral on-topic antibiotics due to recurrent infections, and we use analgesia as well before the treatment. Now he's 18 months of age, and these blisters are persistent and recurrent, mostly or more severe in the hand and feet, with palmoplantar keratodermia, dystrophy of the nails, growth delay, problems with motor and different activities. He is hoarse as well, and this could be related to the laryngeal granuloma. So that could be related to some involvement, some laryngeal involvement. We found an article as well of a patient with generalized severe epidermolysis bullosa simplex in the same mutation, and this hoarseness And it mentioned as well the laryngotracheal involvement as a sign of early lethality, but with good prognosis in the long term. Just to give a short summary, this is a multisystemic disorder, is hereditary of the tissue at the epidermis level with severe fragility of epithelial tissues, especially epidermis, but also the laryngeal and esophageal tissues. And they have a variable severity spectrum. There are different classifications. They could be simple of the junction, dystrophic or mixed. Within the simplest, the most frequent are the localized, intermediate, and severe that it used to be called down in mine. There are 7 described mutations with 7 subtypes. The physiopathogenia is in the most frequently the keratin 5 and 14. And these are the most frequent mutations related to the cytoskeleton. There are other mutations that we did not find in our patient. These are structural mutations found in the desmosomes and hemidesmosomes in the cytoskeleton, both in the cell-to-cell and in the mutation is going to affect the assembly of the keratin. And in the clinic, at the big onset of the symptoms is at birth. You see these big generalized blisters. They could be hemorrhagic or herpetiforms in all the body, but especially in the hand and feet. They can heal without scarring, and they could have hyper or hypopigmentation. With dystrophy of the nails, the symptoms tend to improve in time. This could relate to problems in food intake. There's a lot of catabolic involvement and repeated infections, and they usually die due to septicemia, malnutrition, and electrolytic problems. The most frequent is the autosomic dominant. The recessive are rare, and the novo is the one that we found in our patient. This is a very severe disease, both for the patients and the families. Even though it has a great involvement of the skin, they almost have no systemic involvement. The symptoms usually improve with time. And it's very important to confirm the diagnosis with the molecular study and not just with histopathology, because this will help us find the mutated gene, and we can give correct support and treatment to the for the family, and the reproductive options for the family and the patients, and perhaps some genetic therapy would appear in the future. We want to thank CEDIGEA for supporting us with all our patients. Thank you very much. Thank you, doctor, for the presentation. And we will move on to the next case by Dr. Fernandez from the Debra Foundation. And the other authors are Dr. Belén Marcasio, Dr. Di Andrea, Dr. Pretaglia, and Dr. Cesar Salas Alanis, pathologists and dermatologists in the group. The last doctor is from Mexico, the others from Argentina. Thank you very much. Thank you, CEDIGEA, for the support and the invitation. I'm going to start talking about the paradigm of skin carcinomas in EB patients. This is a frequent complication of one of the epidermolysis, the dystrophic recessive severe generalized variant, but there are some cases published in dominant and lesser in the junction. The risk of developing carcinomas increases through the years. It's 7.5 at 20 years of age, and almost 70% at 35 years of age, and 90% at 55 years of age. Due to the severity of the disease, they could have multiple carcinomas, and this will relate to the early age, the chronicity of the wounds. It usually is aggressive and metastatic, and is molecularly indistinct from other SCC or squamous cell carcinomas. Due to the multiple lesions of these patients in general with this subtype of EB, it is very difficult to clinically diagnose SCC or even suspect it. So we need to base our diagnosis in a high index of suspicion if there are chronic ulcers, more painful ulcers, nodules, hyperkeratotic areas, and wart areas, as you see here in this patient and this other one. For a correct diagnosis, it's mandatory to have more than one biopsy of suspicion lesions to avoid problems and to have a correct diagnosis. This is a 40-year-old patient with a clinical diagnosis of EBDR, severe and generalized, without a diagnosis of genetic diagnosis, with a sister that had died of the same disease at 24 years of age, and with multiple squamous cell carcinoma that started at 31 years of age, and of an amputation of a leg in 2008, of a carcinoma with these characteristics in the past. These are the lesions. Nodular 3 by 4 centimeters, differentiated squamous carcinoma without vascular lymphatic of perineural invasion. This patient had chronic ulcers as well, very painful ulcers that were treated with surgery and the amputation of a leg. In 2008, we have this in the gluteus, very fast growing and very, very painful. It was treated with multiple topic treatments without success. As you can see here, we have a very delineated edges, a lot of granulation tissue, and we have a biopsy done in this year. You can see here atypic proliferation with glands and ducts with variable lumen, and you can see the mucinous aspect on the interior of the cavities, and it was muciparous adenocarcinoma. Of course, this was a surprise. We can see with more magnification the ulcerated surface of the skin, a lot of homogeneous pink material made up of fibrin with cellular remains in the bed, and these solid cords found in the histopathology are in fact represented by atypical cells that still have not turned into glands or ducts.
Bien estas glándulas de tamaño variable y los
variable
cordonesones
size in stroma with collagen, dermal, and the multiparous cells inside. It is also important to point out these perpendicular vessels that are not normal. They are perpendicular to the epidermis. They are dilated capillaries that should be horizontal and show a repair intent. Also, here we see this duct. In fact, it's limited by atypical cells and mucinous content. Here we can see the fibers. These are glandular spaces between dermal collagen spindles. After the diagnosis is made and confirmed of mucinous carcinoma, the main challenge was to differentiate a primary carcinoma from skin metastases. They corresponds to ovarian, breast, or gastrointestinal tract cancer. So we did immunohistochemistry in June last. So we saw mucoblasts here that swim in this mucose content and have cytokeratin 20. That is a marker of gastrointestinal epithelium with CDX22. That's a nuclear marker. It was positive for cytokeratin 20 and CDX2 and negative for cytokeratin 7, estrogenic receptors, and Ki67 confirmed the colorectal etiology. The proliferation growth, 80%, means that many cells are splicing, dividing, so that's a bad prognosis. So the diagnosis was dermal infiltration of mucinous adenocarcinoma. The immunomarking profile favors the intestinal etiology of the lesion. We performed some ancillary testing, chest CT, chest abdomen and pelvis CT. There were nodes. There were retroperitoneal, pre-aortic, lateral aortic nodes that were increased in size. The same with the PET scan showing node structurals with adenomegaly, more uptake. The thyroid gland was heterogeneous, and there was a metabolically active skin thickening in the posterior cervical region in the gluteus and the left lower limb stump. The patient has not undergone any diagnostic colonoscopy due to the progression of disease, the nature of his disease, because in terms of complications that may be brought about by colonoscopy, he has started chemotherapy and radiotherapy with capecitabine a week ago. Well, the interest of this presentation is related to the low incidence of skin infiltration due to cancer. It's only 0.7% to 9%. Most of these patients come from visceral carcinoma, and colorectal cancer is rarely metastasized to the skin, less than 4%, as in this particular case that we suppose is the case of colorectal cancer. Now, the most common location in the skin is rectal cancer, 55%. Even as high as 1/3 of skin metastases are diagnosed before or simultaneous with the primary. So the role of a dermatologist is vital in these cases. The diagnosis is evident if there's a proliferative mass, but it can manifest as ulcers, as in this case, or nodules, rapidly growing nodules that can also become ulcerated, or like any lesions. So it's the first case reported in the literature with this diagnosis in patients with EB, and it's also rare in the general population. Thank you very much for your attention. Thank you very much, doctor. So now we will have some minutes for the comments. Very interesting cases, of course. Maybe the first case first. Inversa dystrophic EB by Dr. Giovo and Dr. Cristina.
Okay. Can I comment?
Puedo
Thank you very
comen-
much. Very interesting presentation and very special cases. Thank you very much. So the first inversa, very special phenotype. My question is whether there was some pruritus or some initial lesion in the vulvar region that was then just perpetuated in one of the siblings. Of course, both have this predilection for folds, but it seems that there was some initial lesion in this girl that did not heal at all and just became a chronic wound. This is one comment. I was curious if this would be possible. And the second comment on this case is that it's not a mutation in exon 3, which is determinant here. It's probably the second mutation, the glycine substitution, that is more associated with this inversa phenotype, I would think. Thank you.
Gracias, doctora.
Thank you.
Doctora María
Eh,
Asuncion, un comentario del
No, yo
primer
comentar
caso.
que es un caso excepcional. Yo
Well, that's
personalmente,
an exceptional case. I have never seen a case like this.
y es un comentario, ¿no?
It's a comment. These patients, the diagnosis is okay, but a patient with an initial problem like this, without a history and controls in the vulvar mucosa, well, this could have been taken by maybe sexual abuse or blistering lichen, atrophic lichen, or pemphigoid disease. Well, a very, very interesting case and very, very difficult because, well, I can't think of any other option more. It didn't work. The gel didn't work. Flor, you know more about the outcome, but before going into the details, this little girl, the other sister has dystrophic EB, but the other sister has no lesions in the folds or in the mucosa, only in the esophageal mucosa. This girl is the only one with the vulvar location, and there was no previous damage. Even when it occurred at the age of 13, when she had this genital lesion, I thought about a diagnosis. I thought about lichen, erosive lichen, but she had no pruritus. She never had any itching. She has pain, burning. We cannot even touch her, but it's not pruritus. Well, let me clarify. She is a patient of mine. When she uses the oleogel, she does well, but like any teenager, it's very hard to get her compliant, you know. Can I make a comment? Well, speaking about the mutation and the variants, I have several patients with the other variant in exon 107, and they behave the same way. We don't believe it's an inversa variant, but it's a highly mucosa involvement variant because they don't have fold involvement, but they are characterized by just a few skin manifestations and mucosa involvement that starts at the age of 5 without any previous manifestation in the skin. So we believe that it's not inversa. This variant is not inversa. It's There's high involvement of the mucosa. And also there's vulvar lesions. And there's stenosis and
That is why the diagnosis is usually difficult. And we think that and they have blisters, and we check more the skin than the mucosa, and the mucosa is where the involvement happens. The skin, well, yes, the skin is better, but there is some loss of nails or some dystrophia that can give you, and I think all of our patients have problem in the nails. No, she has great hands. She has some dystrophic nails, but a little bit. There's been no loss of nails. Some nails are dystrophic. Yes, as you said, all of my patients have nail involvement, so I don't know if it's simple or dystrophic. Well, the sister has esophageal stenosis, and she had to have dilation, balloon dilation, but the genital mucosa is okay. So it's very confusing, and we don't know. Yeah, they have different manifestations. Yes. But the thing is, the thing that repeats in most patients is that the skin involvement is much less involvement of the skin and much more involvement of the mucosa. And the second case, do you have any comments related to the second case? Yes. I wanted to comment about the mapping. Yeah, that's a small problem that we have. We do not have a lot of mapping. Hopefully next year. We have immunofluorescence for all of the autoimmune, but when I ask for our area of collagen, etc., the truth is that we don't have it available. And when we had it done somewhere else, it was not compatible with our molecular findings or even the clinical findings. We have done one, perhaps we should perform several or have someone specializing in this. When we ask for desmoid or collagen, we don't get good results. They give us something else. It's something that we're missing. So that is why we usually turn to the molecular. Perhaps we should perform those tests. And we usually did molecular testing, and the testing was always with previous biopsies, and not always they coincide, the biopsy with the results with what we saw in our patients. So that is why with the clinical manifestations and molecular testing, we have good results. Yes, I don't diagnose until the moment I have the molecular diagnosis, but the mapping, yes, could be confusing in some cases. That is a subjective evaluation on my eyes. Dr. Haas, do you have any comments?
Yes, it's a very important point. In these neonates, the skin fragility is very pronounced, and the question is, will they survive? The question is, are they junctional severes or something else? What is the prognosis? So there are some clinical features that are quite similar, also involvement of nails, but the involvement of palms and soles really indicates this severe simplex EB, and also the extreme fragility. So if you touch the skin, you get a blister, and this is not junctional Hurlitz, but is a simplex. And if you make a staining of laminin 332 in the skin, this is already very important to exclude a Hurlitz if you are not sure about this. And then if you see that the blister is intraepidermal, then it is a severe EB simplex. And sometimes the epidermis is destroyed and you see this acantholysis and everything is chaotic, but this is what happens in these severe forms. So it's important to have a skin biopsy and make even a limited panel of antibodies, because simplex you cannot diagnose so easy with antibodies, but you can exclude the other forms which are lethal. And then there are these small clinical clues that are also very helpful until the molecular genetics comes. But in our experience, also ethical committees, ethical decisions, if this child is very sick, if palliative measures should be started or not, or the child should be kept with all the measures at life, that require molecular diagnostics. We have such discussions. I don't know if you don't have.
Any other comments? So let's move on to the third case. Very interesting case, of course, exceptional. And difficult to manage. Congratulations for all the studies you have performed. Thank you, Asuncion. Thank you, Dr. Vicente.
Very interesting case, indeed, and very well managed. We are curious about the outcome and what will happen with this patient. Probably the longer the patients with severe recessive dystrophic EB survive, the longer we will have such cancers that occur, like also our esophageal carcinomas and other gastrointestinal tumors, maybe.
Sí, doctora, recién está iniciando su tratamiento.
He has just started chemotherapy and radiotherapy, but with no diagnosis of the primary. That's why we will see what the outcome is after starting this treatment, because the lesion, the wound in the gluteal region is very hard. The quality of life is seriously affected. And also, apart from all the lesions the patient has, and some active lesions, and they are epidermoid carcinoids in other parts of the body. But he really wants to live. He wants to undergo genetic testing now after so many years. So with Dr. Amarcaccio, we will try, and well, she's very close. She's from the province of Buenos Aires. Is not from this capital city, so she will be in charge of guiding the patient to Serigea, the blood sample to Serigea. Well, it's a really emblematic case. And so we have to be all very, very closely paying attention. We also have to study the esophagus because of the adenopathies. All the regional nodes are affected as well. Very interesting cases. Thank you for your participation. Congratulations for everybody, all the speakers and the commentators. It has really been an honor to listen to all of you. Thank you. We have learned a lot from these challenging cases. this adolescent sexual life and the consequences, and an adult patient even with this neoplasm. So thank you all very much for sharing the cases and your experience, the experience of the commentators. Dr. Graciela Mansur. So over to you. A very big kiss, a very big hug for my two professors. And now we will continue